Here we are, last day of the conference, and they save the best for last. You know how when you're having that piece of cake and you always save the best piece? Here they are, okay? Now, my name is Wendy Weidner. I'm head of research and publications at ADI. I've been waiting for this moment for 4 years, and I'll tell you why. Because at STRiDE, we're a family, and we haven't seen each other for a long time. I'm going to get emotional, I'm sorry, but I'm telling you, we have worked so hard on this project. We cannot wait to tell you about it. But it is a family that has worked together, and I want everybody who worked on STRiDE to stand up, please, because everybody needs to. We've got representatives here, but all of these people worked on this. So give them a round. This was a broad and complex and ambitious project across 7 low and middle income countries. And the thing that ADI really loved about it, because it was translating research and evidence that's very important into something practical, into policy change and impact. Now, this is a unique project because it brought together research and civil society, our Alzheimer's associations, because there was a recognition. These guys have a lot of evidence and experience on how to gather evidence. These guys have a lot of experience and unique expertise in how to translate that and make change. And when we brought the two together, it was this magical recipe. It was so unique, and it continues to be that way. And it was also about building capacity, and that leads to sustainability. And so today, we've got our presentations. We're going to go through them as quickly as possible. I encourage you to ask questions. But first, I'm going to ask Adelena Comasuera to come up to just do a quick overview of STRiDE. She's the co-PA with Dr. Martin Knapp, who's here in the audience with us. She's going to come and just give you a quick overview, and then we'll go into the presentations.
So first of all, thank you very much for coming. It is, as Wendy said, it's a very emotional time for us to be here. It's the end of the project, but in many ways, also the beginning of the next steps and of the future. So STRiDE stands for Strengthening Responses to Dementia. Now, our funder wanted to call it in developing countries. It's not our favorite language, but we have to use that for now. But the thing is that every country in the world needs to strengthen responses to dementia. And I'd like to start by saying this was a building capacity in research project. I think the funder thought it was only going to be north to south, that kind of thing. In reality, it's been nothing like that at all. I have to thank every single one of you for increasing my capacity extraordinarily in this rich, wonderful, and also complex and challenging, because quite a lot of unexpected things happened along the way. But this has been an amazing dream and an amazing project, and I really can't wait to see the next steps. You're going to see some fantastic presentations. Most of you will have in your chair an announcement of an event that we have next Wednesday, where we'll be able to have more time to go into everything, and also an event where we will explain some of our ideas for the future and how many more countries, many more areas of research and policy can come in and contribute to continue strengthening responses to dementia in any country in the world. And here we go. Just wait to be amazed. Thank you.
Well, thanks, Adelena. Okay, so without further ado, I am going to introduce Fabiana Da Mata, who's from, I'm going to butcher this now, Universidade Federal de São Paulo in Brazil. And she's going to talk to us about how we're accessing ongoing dementia care in Brazil. Fabiana.
Good afternoon, everyone. Thank you very much for coming, and I'm very happy to be here today. And I'm going to present the work that we have been developing entitled Accessing, Diagnosis, and Ongoing Dementia Care in Brazil, Analysis of Case Vignettes. So I have no conflicts of interest to declare, and I'm grateful for the funding that has been awarded to us during the whole project. So first, I will give you a brief presentation about the dementia care in Brazil. Then I will show you how we developed our study. Then we will share with you the main findings, and then we will close with the conclusion. So in Brazil, Brazil has been through a rapid aging population process, which has led to increase in the number of people with chronic conditions, including people living with dementia. We know that dementia is one of the most disabling and costly conditions among older people, and because of that, many global policies have emerged, and with the aim of advocating towards a better care, a better dementia care. For example, we have the Global Action Plan on the public health response to dementia, also the World Alzheimer Report. But, however, in Brazil, we don't have dementia-oriented policies. Actually, they are almost non-existent. They are still very incipient. And although we do have nowadays a law project, it's a dementia-care strategy that has been submitted to the Brazilian Federal Congress and is being consideration nowadays. But it is still it's being discussed, and we don't have doesn't have finalized this also so far. And so in Brazil, older people living with dementia, they have the same right to benefit from the same health and long-term care services from older people living without dementia. However, nowadays in Brazil, the country lacks a clear understanding of what services and support people living with dementia access, and when and how they access these services, how and when they move across different services and different sectors, for example, from health to long-term care. And also, we don't know about the contextual and individual factors that affect care, access, and use. So our overarching aim was to inform and contribute to developing dementia care pathway tailored to the Brazilian context. Specifically, we wanted to map the available types of services for diagnosis, post-diagnosis, and long-term care related to dementia. We also wanted to understand the most likely care routes people living with dementia may take in Brazil, and to identify linked social demographic characteristics that might influence service access, and finally, to identify gaps, barriers, and enablers for accessing services. So our work is part of the STRiDE program. It's a program that is led by the London School of Economics, which aims to strengthen response to dementia in low and middle income countries. So some of the countries that are part of STRiDE are Brazil, India, Indonesia, Jamaica, Kenya, Mexico, and South Africa. So in our work, we based our work on the development and creation of case vignettes, and our methodology was divided in 5 steps, which I will present to you as follows. And this study was approved by the research ethics committees from both Brazil and the UK. So our first step was to create the vignettes. So we created 10 vignettes which depicted histories of people living with dementia, and we included social demographic characteristics from Brazil. Then we developed and wrote the content of these vignettes, I mean the trajectories of these vignettes, describing the likely access to the diagnosis and care that each person with dementia would take in the histories in the vignettes that we had created. So we developed our vignettes based on probe questions, which are part from the STRiDE methodological framework. We also based the development of our vignettes on a desk review that we conducted as part of STRiDE, also on a SWOT analysis, I mean a strengths, weakness, opportunities, and threats analysis of this desk review, and also on the results of interviews and focus groups that we developed with some stakeholders, such as people living with dementia, carers, healthcare professionals, and etc. We also externally validated our vignettes. We shared them with healthcare professionals, academics, also shared them with members of the STRiDE Brazil Steering Committee and other STRiDE country teams, so we received feedback about them via email. In terms of data extraction, we based our data extraction on the framework method, from which we could have a tabular overview of the vignettes, and then we followed 13 key questions, which included where to access health and long-term care services, the likely family arrangements, and what would be the impact of formal and informal care arrangements on people living with dementia. For our analysis, we also based this on the framework method. So from this tabular overview that we built, we could compare the content across and within the 10 vignettes. We could consider gaps, barriers, and facilitators for diagnosis, care, and support. And we also could reflect on whether differences and similarities were likely due to some key a priori social demographic variables that were initially explored in our vignettes. So here is just for you to have a sense of how the vignettes look like. So we have first a first part of the vignette, on which we create the context, put the context of the person living with dementia. So we gave some information such as sex, age, place of living. And then we developed the vignette where we really told the likely trajectory that that person in those conditions, in this context, could take in terms of accessing which services in Brazil. So we said, for example, which would be the most likely person that healthcare professional that this person would meet, or what type of consultation that she will take. It would be a home-based consultation or in the primary care unit-based consultation. And then we have many of these examples. For example, we have developed the scenarios. So we have a scenario of a person living in a slum. We have a scenario where a person was living in an indigenous riverside community. We have another vignette telling about a rich person. And you can have access to all our vignettes, the complete versions of them, through the STRiDE website. They are all there. In terms of access to diagnosis, we could identify some care pathways, main care pathways. So before that, in Brazil, we just need to remember that in Brazil, we have two kinds of healthcare systems. Yeah, we have the public sector, which is state-funded and it's universal. And we also have the private sector. So in the public sector, we know that a person living with dementia would most likely be treated, will seek help first from the primary care. So she could go to a primary care unit, or she could receive home care services if she is part of the family health strategy program, for example. In this case, she would see first the GP and then be referred to a specialist doctor. In the private sector, a person living with dementia would go directly to a specialist doctor. She could even go to a GP first and then be referred to a specialist doctor, but this is not the most common situation. She would most likely go directly to a specialist doctor. And people living with dementia might also seek help from traditional healers in Brazil. We also identified some social demographic characteristics that might be influencing these care routes. So, for example, if a person has a good financial situation, it's most likely that she would be going to a private sector. And but if she lives in an urban area, for example, she might seek help from the public and private sector. If she lives in a rural area, it's most likely that she would be going to seek help from traditional healers. In terms of post-diagnosis and long-term care, we also have the two sectors, the public and the private. So in the public sector, there are three levels of, it's most likely that a person living with dementia would benefit from the three levels of care, would be the primary, the secondary, and the tertiary. And also she could go to long-term residential services, although they are not enough in number in Brazil. And the person could also seek help from the community-based services, such as psychosocial or outreach health services. In the private sector, she would also be entitled to go to seek help from the three levels of care, from long-term residential services as well, but they are also not enough in numbers, and to seek help from outreach services, psychosocial support, also from non-governmental organizations such as Febrise and its institutions and its associations, and also to get some kind of help from informal support, which we mean by the communities. So we also identified some social demographic characteristics that might be influenced this. For example, if a person has a good financial situation, she also will be seeking help from the private sector. If she lives in urban areas, she can have the three levels of care from the public and from the private sector. also the community-based services from both systems. And if she has a good level of education, it's most likely that she will be reaching support from outreach services and psychosocial support from the private sector. And depending on the family arrangements, she will be going to long-term care residential services from both private and sector, although we know that these are not enough in number, and there is also some kind of stigma associated to these residential services in Brazil. So it ends up not being like a very common pathway for people living with dementia. So we also identified some gaps in barriers to accessing dementia care in Brazil, as for example, poor awareness and poor training in dementia. We also identified stigma, which might lead to no diagnosis disclosure, also to dementia as being faced as a natural part of aging. We don't have the family health strategy program in covering 100% of the municipalities in Brazil. We also lack enough public transportation and good quality public long-term care facilities, and there is no formal caregivers or daycare centers funded by the government. However, we also identified some facilitators, which will be the Brazilian Universal Public Health System, which covers the 100% of the Brazilian territory and delivers many different services such as primary care units and domiciliary services, which can reach even the most remote areas. So to conclude, dementia-oriented services are almost non-existent in Brazil. Nowadays, the country's considerable diversity in economic, geographic, cultural, and educational factors might influence access to a diagnosis and care in the dementia care routes. Access to dementia long-term care is challenging given the lack of investment in social care, dementia-specific services, and awareness. There is not enough training of healthcare professionals and not enough population knowledge and awareness. Having a universal public health system facilitates access to new dementia-oriented services, and there is a need to better fund and expand the services provided by SUS, including dementia, as a priority. So our next steps in the STRiDE Brazil project is to estimate the current and future costs of dementia care to society in Brazil. So thank you very much for your attention, and I'm happy to take any questions now or later.
Whew. Thank you, Fabiana. So much work that went into that. Fantastic to hear about the whole vignettes. They became so important, we had no idea. Next, coming is Suvarna Alladi, who is from the Department of Neurology in India, and she's going to talk about the policymaking process.
So very good afternoon to all of you. And I am grateful to ADI and STRiDE for inviting me to be here today. I represent a very vibrant STRiDE India and UK team, and on behalf of all of them, it's a privilege to share some thoughts on this study that we did on expert perspectives on the policy-making process and scope for dementia care policy and practice in India. So we've heard from Wendy that the two main asks from the STRiDE project were to impact policy, to work towards developing a dementia action plan for our country, and the second was to develop evidence, fill those gaps, so we could inform policy. So we've spent the last 4 years actually working on identifying the gaps that are there in India. How do people who provide care, what are the impact of providing care on them, what is the meaning of stigma in an Indian context, what interventions work, so across very many different work packages. But what was unique about STRiDE was that from very early in the project, we were also trained on the importance of using this evidence to impact policy. So I think at the end of 4 years now, the onus of responsibility for all of us is to make it possible for all this hard work that everybody has done to actually reach the policymakers and understand what this process is about. And I think that capacity has been built. We're very grateful to STRiDE. The fact that there are so many people with dementia in our countries means that while we have many efforts that are ongoing at an individual level, at an organizational level, I think the difference the maximum difference will happen if there is a from the top, if we have a policy that influences the lives of millions of people with dementia who live in our countries. So that is why this particular exercise will be very useful important for us. We did a very an in-depth analysis of the status of dementia care in India. And I'm a neurologist, and we now know that dementia is a complex condition. It's multifactorial in etiology. The care is multidisciplinary. The problems are very diverse. So it's no surprise that care of people with dementia will be distributed across different forms of health systems. There is no national level program or policy specific to dementia as I speak in India. But there are several programs that have been identified through the situational analysis that can potentially be used, and and our research can be used, and we can plug them into the programs for elderly care, for non-communicable disease care, the National Mental Health Program. We have a national program for palliative care. And within certain states, there have been good examples of what actually works. More recently, the Karnataka Brain Health Initiative, which I believe is an offshoot of the STRiDE project itself, where policymakers are actually listening to us. So the aim of this study was to gain expert insights on the factors that influence development of national policies or programs, to determine the status of dementia in existing national programs in India, to understand how policies are made in general and how dementia-specific policies are made, and then to make recommendations for dementia in India based on expert input and experiences. So this was a guide that was developed under the leadership of Adelina and her team. We have an interview guide that was developed on how we have to engage with policymakers, what kind of questions we could ask them, a more general guide for, I think, across countries. And then we were taken into confidence, and we had an opportunity to include some questions that we thought were more relevant for the Indian context. And the other thing that happened was, while we had a range of stakeholders, when we started the interview, it was Jaita, I, and Narinder, who actually interviewed various stakeholders. So we had a meeting where we would think, okay, so this is a person, this is his or her expertise, and say maybe we can actually ask them specific questions from the guide, so we can get information that is more relevant to this process. And then an analysis was done. I must mention this is still very preliminary, but already the results are interesting, and we hope to do a more in-depth analysis. We had people from different countries. We had men and women as stakeholders. And since it's policy, we had a lot of government officials that we interviewed. This was an opportunity for us, people who are actually working actively in, say, a program that is successful today. So talking to them about how they did how it was possible for them to work with their program. And then some retired health officials who had an experience of 40 years with the Indian system of policy making. We had neurologists, geriatric psychiatrists, geriatricians, and public health specialists as well. We had health economists, and we had NGO heads, and we had people working with dementia for a long time. So to begin with, a little understanding of their awareness about dementia itself, because some of them really haven't worked with dementia, and some of them have a lot of experience with dementia. You can see that what we understood is that over the last 20 years, for people who have worked in the field, there is awareness about dementia, and it's growing quite rapidly among people who work with dementia. And even those that don't actually work with dementia, they kind of know that this is a big problem. So everybody knows that it's a big problem and it's coming. So that's the good news. But then when you talk to them about organizations working with dementia, there wasn't that kind of an understanding of whether it was hospitals or memory clinics or dementia organizations or Alzheimer's associations. What do we do? So do they do some research, or do they do some caregiving? So there was not a clear understanding about what dementia organizations do in India. And then when we asked them about their opinions, policy, this was where we got most heterogeneous responses. On the one hand, they said, no, we definitely need a dementia policy. On the other hand, if we don't need a dementia policy, we need it to be integrated into the existing program. So I think it's a good time for us to actually influence, if we have robust evidence on how we can, because people are still making up their minds. They're sure that we should do something for dementia, and there are people in India doing it, but how do we do it? And this is very heterogeneous. So I think this will be a theme in one of our analysis about policy for dementia. So then we looked at what are the factors that can influence the development of national policies or programs, and this is the work done by Jaita and Sadia. Capacity has been built, so they're doing most of the work. So these were the several themes that have been identified. What are the political factors that influence programs or policies? In what context do they develop? How important is evidence really to develop policy? And some local examples of good practice came up, and clearly there was a need to integrate with existing programs, and most importantly, the role of advocacy. So what was interesting about the political factors was, while they said, yes, we need policies, but some of the policymakers said it has to come from organizations that are working with dementia, people with dementia, that families create models that work, and then take it to policymakers, and then they will, it's easier to implement it. So again, it's not just from the top. We have to engage with policymakers for a political will to develop. That became clear. There are always going to be competing interests, whether it's malaria or tuberculosis or more recently COVID. So where does dementia feature in this? So that came up, it's more important for us to take care of communicable diseases or something. So what we begin to understand is we have to develop resilience while there are competing interests. There are always going to be competing interests. So we have to have a way in which we are resilient in our way in which we engage the policymakers with dementia. But what was really encouraging was across board, all stakeholders said that evidence will help. So they're not doing it arbitrarily. The people who have worked in policy before said, so whatever research evidence you have is going to be very useful for us. And there were certain examples of good practice, which I think these models can be scaled. They're there in our situational analysis. And so this is something that we will need to keep working on. And it was stressed that you can have a national dementia policy, but it has to be integrated with existing national programs, because the thrust now is on all of these national programs. So we have to learn how to work along with them. And again, very importantly, consistent, intense efforts at raising priority for dementia among all of us. Advocacy was highlighted as one of the more important ways forward. So you can see that these are some of the themes that are still emerging from the transcripts that we have read and tried to understand. But it's been a great journey, and I believe that this will actually help us in developing robust recommendations for policy, which is one of the key objectives of STRiDE. Thank you very much.
Well done. Thank you. Thank you so much, Suvarna. It's so interesting to see all of the facets that go into those making policy and using that evidence. Now, the reality of the world is now that not everybody was able to make it, not all of our STRiDE members. And one of our colleagues sent in a video with her presentation. So she's going to be next. This is Christine Musyimi, who is with the Africa Mental Health Research and Training Foundation. So please enjoy her video.
Hi everyone, I'm sorry I'm not able to join you this year, but I'm looking forward to join you in person in 2023. My name is Christine Musyimi, and I have been a postdoctoral researcher on the STRiDE Kenya project for the past 4.5 years. And even as I share my presentation, for the past 4.5 years, we've been able to develop the dementia anti-stigma intervention, and we've tested it among 59 members of the general public. Just to give you an overview of why we developed this intervention is because in Kenya there's a lot of stigma on dementia, and stigma affects the quality of life of people living with dementia and their families. Yet there are very few interventions or lack of interventions in developing countries, and most of the reports has been reported in developed countries. In Kenya specifically, there are negative perceptions, and these negative perceptions of dementia attributed to dementia being part of normal aging, or dementia being due to witchcraft. And this results into many families of people living with dementia being neglected or abused, and or even reduced access to care, and you realize detection is performed at very advanced stages of dementia. We also found that in our baseline assessments before implementing the anti-stigma intervention, that 82% of respondents believe that dementia is caused in part due to normal aging, while 74% of the respondents believe that people living with dementia are dangerous more often than not. And that's why they're usually locked up, they're neglected, and even abused, because people don't want to assume that people living with dementia are likely to cause more harm. We also found that out of every 10 individuals, 9 individuals believe that people living with dementia do not understand simple instructions. And that's why probably it's important for us as a country to identify dementia as an early stage, so that we know that actually people living with dementia can be able to receive care, and they can be able to understand simple to complex instructions. 75% of respondents also believe that people living with dementia need to be worried about discrimination by doctors and willing to provide treatment, which is really mainly attributed to stigma at all levels of care, including at the family level and the healthcare settings. So based on this background and research, we sought to develop dementia anti-stigma intervention using the MRC framework for developing and evaluating complex interventions. And we used, based on the structure or the instructions from the MRC framework, it requires academicians or researchers to select one of the evidence-based approaches to intervention development. And for us, what was important is to be able to identify a simple and systematic approach to systematic development, and we selected the 6 steps in quality intervention development, which is the 6 STRiDE model that I'll be discussing in the next couple of slides, and which uses an evidence-based way to maximize likely effectiveness in the future. Just to understand, as a first step for us was to understand, and even according to 6 STRiDE model, is to understand the nature and the extent of the main problem. For us as a country, stigma was a big deal because most individuals attributed to witchcraft or normal aging. And again, there are limited interventions to address stigma surrounding dementia. And in terms of the causes and contributing factors to dementia, is because there's lack of knowledge. There are also lack of policy guidelines in terms of dementia treatment. And there's negative interpretation of the term dementia in our local setting, especially in the study site that we did this work. The term dementia is used as pingai. The local term for dementia is pingai in Kambani region. And pingai originated from the word thinking high, which is interpreted as what goes up must come down. And other causes that are most important, apart from the negative local interpretation, is lack of knowledge. And their consequences is one of the things that we need to understand the problem. Apart from stigma, the consequences attributed to that stigma could be immediate or long term, and there could be fear, social isolation, shame, guilt, or lack of access to care, as well as other physical and mental health conditions. We also identified the causal factors as a step 2 of the STRiDE model, the causal factors that have the greatest scope for change. And we looked at the healthcare facility level stigma, where healthcare workers attributed dementia to normal aging. We also had stigma from the community members, as well as structural stigma. And from my right, we have structural stigma, and one of the carers said that, I have not heard about other organizations dealing with dementia. Nobody cares about people living with dementia. It's all been left to us to take care of our people. So you can tell there's a lot of gap among committee members. We have published this work in Dementia Journal. Feel free to access the specific excerpts and more in that article. In step 3, we were able to identify the check mechanisms that will help us to increase access to dementia care, as well as sustainability in terms of this intervention, which is directly linked to step 4, because we're using the change mechanisms to deliver the intervention. So social contact has been shown to be one of the most effective interventions known to reduce stigma in the short term. And based on this background, we use the trainer approach to train community health volunteers in using 4 psychoeducational group sessions. And the community health volunteers or workers delivered the intervention to members of the general public. In terms of social contact, which was shown to be most effective, one of the most effective interventions to reduce stigma in the short term, we employed video-based social contact intervention in one of the 4 sessions, where people living with dementia and their carers were able to share their experiences. And the intervention was expected to take either weekly or bi-weekly and between 60 to 90 minutes. So we also used as a change mechanism the apprenticeship model, which has been shown to be very sustainable when it comes to implementing local interventions. And the STRiDE Kenya team, who developed the intervention among other partners within the STRiDE project, trained community health extension workers. And the community health extension workers later on trained community health volunteers who are the counselors. And then the counselors deliver the intervention to clients or members of the community, members of the general public, using the 4 session cycle education sessions. This is how the intervention looks like. We have 4 sessions. The first session is understanding dementia. The second session is about addressing common myths and misconceptions, and specifically addressing the attributions of dementia to witchcraft and normal aging, as well as using appropriate language towards people living with dementia. Session 3 was around using indirect or video-based social contact to address human rights, and session 4 was about including people living with dementia and their carers using a case vignette. 5, according to the STRiDE model, is about testing and adapting the intervention. And that's what we did. We trained 10 community health workers or volunteers to deliver the 4 bi-weekly group sessions. These sessions can be delivered weekly or bi-weekly, but in our context, bi-weekly was still considered to be useful. And the sessions took about 1.5 hours to 2.5 hours, and the intervention was delivered to 59 members of the general public, but in a group format of 10 to 12 members. And the findings following 1 month after intervention, we had one member of the general public mention that I can relate with people living with dementia and their carers, because it is not their fault. We also had a carer of a person living with dementia sharing her experiences and how she's been able to take care of a person living with dementia. And she said, previously I had challenges relating with my mother since I was not allowing her to perform any activities. I have recently learned to be patient, responsive to her needs, and allow her to perform any pleasurable activities at home and provide supervision for activities that need my attention. And we are now relating well. So in conclusion, it is important to involve people living with dementia and their carers, as well as key stakeholders in developing and implementing anti-stigma interventions by allowing them to express their views, which is important because once we develop interventions, then it's going to be very specific to the individuals and they're able to make decisions about their health and promote early uptake of services. Addressing dementia-related stigma is also important through psychoeducation, can also improve seeking behavior. Our next step is to collect evidence of effectiveness of the program at a later stage using the developed dementia anti-stigma intervention. Please follow us and read about us. Thank you very much.
Thank you, Christine, and colleagues in Kenya who might be watching. Christine, Elizabeth, and David, we miss you and wish you were with us. Next, we've got Mariana Lopez-Ortega from the National Institute of Geriatrics in Mexico, who's going to talk about the experience and cost of caring for people living with dementia and their carers.
Hi. Hi, everyone. Thanks for the committee and the STRiDE project for the opportunity to be here and present some of the results. Sorry, I don't have an introductory or background slide, but I guess that as with the other projects, or sorry, countries, we are a country where Mexico is rapidly aging. Although we have a national plan, it has not been implemented, so we don't have national level policies or programs. There is low awareness and high stigma around dementia. So I think although we're very different countries, those similarities we have. And also, as you can see, we have been presenting very different things because, as I think Wendy already mentioned, there's 8 or 9 working packages, and we're presenting from different ones. So what I will be presenting, it's myself, and also on behalf of my colleagues, Emily Freeman, who is at the London School of Economics, and Rosa Farrés, who's the president of our Mexican Alzheimer's Federation, over there, Rosa. So, as Wendy was saying, we'll be talking about the pathways of care, experience and costs of caring for family members living with dementia in Mexico.
Help with moving the slides forward. Our green button's not working. Oh, there we go.
Oh, okay. Sorry, now it's 10 slides now. So the study aims first to understand the costs of providing unpaid care work for family members with dementia in Mexico, and to understand the associated economic, social, and health consequences of this unpaid care. And as we were saying, all of our countries, we needed, as Suvarna was saying, we need, although probably we thought things were happening, we really need to document, have the evidence, see what's happening, and then when we recommend support services for people living with dementia or their caregivers, we know where we are coming from. Sorry. So what we did was in-depth interviews with people who care or have cared for family members with dementia. First, we did them in person, but of course, COVID came. We waited for a while, and it was still there. So we decided to continue remotely doing these interviews. And depending on the situation, it was either by phone or by video calls, but without the video, just the audio, but in using the platforms like Zoom and things like that. In the end, we did 50 interviews with 23 participants. 1 participant was lost to follow-up, and 2 family members with dementia died during this period. So in the interviews, the first ones with these 2 carers where their family member was still alive, but then the second or third interviews, they had already died, so we could be also the sort of before and after the caring. 3 localities, 2 urban and 1 semi-urban. One good thing about COVID-19 was that we were able to conduct interviews in another state, in the state of Chiapas, because we were doing them remotely, which is a semi-urban and very different situation from Mexico City. So we have now much varied information. Multiple interviews with each participant and a wide range of topics and in-depth discussion. So these are some preliminary results because not only COVID, but doing, I don't know, everyone that does qualitative work, we're doing it in Spanish, having it translated, well, transcribed, translated, and that takes forever. So at 2 levels. First, at the personal level, some emerging concepts that we wanted to share with you. First one is that feeling, a concept of feeling trapped. That the beginning of intensive care provision for someone with dementia is an event that divides one's life narrative into before and after. After signals the end of freedom to direct one's own life. There are no meaningful breaks in caregiving, and there's no way out, or a feeling that there's no way out. Caregiving responsibility is relentless. Um, so, for example, just one quote, because we don't have too much time, but participant 19 telling us, it is very difficult to accept that this is your life. I mean that everything spins around this, around Alzheimer's, and that even if you have lots of money and you have enough to pay someone to take care of her for you and everything, you're always going to be in charge of her, right? It's accepting that your social life has ended, your life, your tranquility. If you don't get on with your spouse, you say, no, that's not my life, I don't want to live this way, so you separate. But here, there's no way to separate myself. I have I have to go on here. There is nowhere to go. So this is one of the very emerging concepts that has come up several times. Another emerging concept is that of restructured lives. Being the main carer of a family member with dementia transforms lives and plans which have to be changed and restructured. There are no alternatives or preferred alternatives. And so changes have to be made, even if they be high opportunity costs and have negative social and economic impacts, as well as impact on health and well-being. So an important number of participants had to restructure their life, whereas changing their jobs, the city where they lived, bringing their family member to live with them or moving with them. We also observe personal habits transform in terms of sleeping, health, well-being, not doing it, being able to do things like exercise or other like healthy habits or things that they used to do. At the structural level, some preliminary results on just to a bit of a summary in terms of the care trajectories and what we have found so far. Long care trajectories, around 10 years, with little or no accompaniment from the health or social security sector. Lack of knowledge, normalization of cognitive decline as part of aging, and a lot of stigma, not externalizing changes, family members not wanting to sort of see that something is happening, grief, and also a great delay in search of care, and consequently little margin to act from the clinical field, and also much more symptoms to be managed. When there is a diagnosis from medical experts in general, not always, but there's little or no explanation on possible changes for behaviors, just like this is the diagnostic, that's it. And we also have found a lot of self-learning strategies, such as support groups, internet, information from Alzheimer's and other dementias associations, or even from health systems in other countries, for example, from Spain. So people that have access to the internet, or other Latin American countries that have some stuff. So, because it's in Spanish, of course. So, high economic impact on family members, as I was saying, because stopping or changing your jobs to something more flexible, but of course less challenging. And we need to give that a value. So that would be one of our next steps. For those, for example, that had a day center as a support resource, they refer to the pandemic as a relevant negative impact, sort of no moments of respite, because of course they were closed. As I was saying, changes in home arrangements and life course development, families migrating to Mexico City or other state capitals to obtain a diagnosis, relevant impact on life and dynamics. And for many participants, we get this expression when they say, you know, in retrospect, there are a lot of things we could have done. Or if I had known this and that, I would have made it different. So this is why having this evidence for us, it's not just the supporting in terms of a policy recommendation, but things that we can do for the caregivers. So just to finish, acknowledgements, of course, the funding from the UK Research and Innovation Global Challenges Research Fund, to all the participants who agreed to take part in the study, and immense gratitude to opening up for us. It's sort of amazing, all the information they shared. To our fieldwork team, you have the names there, the researchers that helped me with the interviews, our team translators, but because if translating just like an academic document is difficult. Imagine what's translating 2 hours of an interview with very local terms and things like that. So really great work. To our national advisor group in Mexico, that's our stakeholders that have been with us, most of them since the beginning of the project, and to all the STRiDE Dementia project for the immense learning and collaboration experiences, because as Wendy was saying, we're colleagues, but we're also friends and family by now. So thank you.
Thank you, Mariana. That was excellent. I'm going to move us along. We've got 2 more videos. The next video, sorry again, it's visa issues. Tara Puspitarini, who's from Atmajaya Catholic University of Indonesia, is going to be talking about mapping Indonesia's dementia care services. How y'all doing? You all right? You want to stand up, sit down? You okay? All right. Okay. Here we go. Next video. Thank you.
Good afternoon, everyone. I'm Tara Sani. I'm presenting here on behalf of the STRiDE Indonesia team. I'm the representative of Alzheimer Indonesia, as well as an early career researcher in this team. Today, I'd like to talk about our process in mapping Indonesia's dementia care system. Please let me share screen. Hopefully you can see my screen now. Yes. So this is our team. We want to talk about our process in mapping Indonesia's dementia care system, documenting its challenges and identifying opportunities to improve it, which is part of what we did in STRiDE's work package on models of dementia care. Indonesia is a country with the 4th biggest population in the world, located in Southeast Asia. We are facing an aging population, as currently more than 7%, or 20 million, of our population are older people, which means more people will develop dementia. Despite that, there are only about 13 cities across the whole country which already have a memory clinic. We've had our national health insurance system since 2014, and it's known as JKN, Jaminan Kesehatan Nasional. We have our national dementia plan since 2016. In 2019, a Ministry of Health regulation was issued calling for cognitive screening for everyone aged 60 or over at the primary care level. Now we would like to know, how has this been implemented, especially in the care system? To understand this, first, we did a desk review to understand dementia situation in Indonesia. Through this, we identified the strength, weakness, opportunity, and threats for Indonesia in terms of dementia. We investigate areas where information is lacking through interviewing stakeholders who are practitioners in health or long-term care facilities. In this case, we recruited 1 neurologist, 2 general practitioners practicing in Puskesmas, a government-operated primary care centers, and 1 long-term care facility and program manager working under the Ministry of Social Affairs. All of them were recruited through Alzheimer's Indonesia's network. If one was to access dementia care, which is funded by the National Health Insurance, this is what they have to go through according to our situational analysis. First, they have to go to the Puskesmas, or the primary care center. Puskesmas is responsible for promotive and preventive measures against non-communicable diseases, including dementia. They are also responsible to do the cognitive screening for everyone aged 60 or over. If suspected to have dementia, the person will then given a referral letter to the nearest Type C hospital to see a neurologist or psychiatrist. If there is none, they might be referred to a neurologist, psychiatrist, or geriatrician in a Type B hospital. Here, dementia diagnosis can be made based on physical anamnesis, physical examination, and neuropsychological examination. However, this hospital might not have facilities to do imaging or specific lab tests to know what type of dementia the person has. For this, the person will be referred in a Type B, referred to a memory clinic, which is located in a Type A hospital. This is usually in the province capital, so sometimes people have to travel for hours or even days to reach this hospital. We asked these questions to our stakeholders to understand the implementation. And here is what we found. At the Puskesmas level, not all Puskesmas has received training on screening for dementia. Even in the Puskesmas that has received training, usually only a few of the staff has been trained, and they feel the need of more people being trained. There needs to be a clear program indicators, what needs to be achieved to enable resource mobilization in the Puskesmas. There is also a need for a clear guideline when to refer. For example, patients with mild dementia are usually only given education and be monitored, while the moderate to severe be referred to hospitals. This actually can delay drug treatments when actually indicated in the mild to moderate stage. Both the GP respondents suggested strengthening the primary care system and enabling a back referral system to allow patients to refill drugs and be monitored regularly at the nearest Puskesmas instead of having to go to a hospital really far from where they live. At the hospital level, apparently the services covered by the JKN might differ across the regions or even across hospitals. In one type B hospital, dementia diagnosis and treatment is covered, but similar case cannot be covered in another type B hospital. This all depends on the hospital and the region's budget allocation. Some type C hospitals might have MRI or lab tests needed to diagnose without referring to type A, but others might not have it. For drug treatment, as for now, only donepezil is covered by the JKN. This proves challenging as some patients who need memantine or cannot stand the side effects of donepezil don't have other choice. Patients also need to come weekly to collect the drugs at the type B or C hospital or a month in type A hospital. Another challenge is when the patient needed to be referred to another specialty. For example, if they are in the care of a neurologist and need to be referred to a psychiatrist or the other way around. Or when they need physio or speech therapy. In our respondents' region, they cannot make an internal referral to another department in the same hospital, although this has been possible in another region. The patient has to go back to the Puskesmas to get referral again, and this sometimes means being referred to another hospital, so they might have to go to several hospitals for different services. Due to the drug side effects or living far from the hospital, sometimes patients and the family choose to pay out of pocket so they can get another drug or services without having to go back to the Puskesmas and start the referral process all over again. Accessing Puskesmas service out of pocket is quite affordable. It costs less than $1 per visit. But tests and treatments in a hospital are quite expensive. It's $200 for an MRI and about $100 for a month of donepezil, which is quite expensive by Indonesian standard. At the moment, there is not yet a standardized pathway for post-diagnostic support. However, in cities where there is an Alzheimer Indonesia chapter, clinicians usually refer the patients to Alzheimer Indonesia for this. There is not yet an integrated referral system from the healthcare facilities to access long-term care facilities such as respite care, day centers, paid carers, or residential care. Patients and families usually have to find such services themselves, except if the patient have no next of kin and no means to fund their long-term care, then the Ministry of Social Affairs will take responsibility. This is our suggested model of dementia care services. Puskesmas still serve as the gateway to screen people for dementia and give timely referral to the hospital. Diagnostic process and pharmacological treatments should be covered by the JKN at all levels. When someone is diagnosed with dementia and prescribed dementia medications, the hospital can back refer them to the Puskesmas, so they can refill the medications at Puskesmas level, which should be closer to their homes. Puskesmas also should be linked up to local Alzheimer Association to provide post-diagnostic support besides education and preventive activities. Local Alzheimer Indonesia chapters can support Puskesmas in forming local support groups and education programs people with dementia and their families need, and referring them to appropriate long-term care facilities or programs. To summarize, here is our recommendation on the priority of improving Indonesia's dementia care system. First of all, we need to strengthen capacity of our dementia workforce and establish a clear guidance to implement standardized dementia services across the country. Strengthening primary care capacity and role and activating a back referral system to allow dispensing dementia drugs and provision of post-diagnostic support in Puskesmas. An internal referral system to access different specialistic services within a hospital should be made available. We need more dementia drugs to be covered by JKN, such as memantine and rivastigmine. We need long-term care system, which is integrated to the healthcare system. And we need to provide remote support for people with dementia and their families who live far from healthcare facilities. To achieve all this, we need a strong multidisciplinary and intersectoral collaboration between the government from different ministries, private sector, and civil society. Thank you for the opportunity given, and please feel free to contact us for questions, discussions, or collaborations. Thank you so much.
Brilliant, Tara. And these guys really did, they put together this fantastic alternative referral pathway and have made strides with the Ministry of Health to talk to them about suggestions. It's been fantastic to see it coming alive in policy. So next we have Roxanne Jacobs from the University of Cape Town, South Africa, who again had a visa problem, couldn't make it here. But she's going to talk to us about an incredible household survey they did in South Africa.
Hello, I'm Roxanne Jacobs, and I'm a research officer at the Center for Public Mental Health, and we're based at the University of Cape Town. So I'm also part of the South African STRiDE team, and today I'm going to talk to you about our findings from a household survey that we did towards the end of last year. So of course, I'm also part of a bigger team, and on the screen you will see the names of all the members that make up the Work Package 5 group. These are just some images from the sites that we visited last year when we did the household survey. Just quickly on our approach, we followed the 1066 short algorithm, where we interviewed an older adult and an informant within each household. The older adult had to be 65 years and older, speak one of the 4 main languages that is dominant in the 2 sites. And questions in this toolkit were asked about the memory, health, and well-being of the older adult. As for the informant, this participant had to be at least 18 years and older, had to either live with the older adult or not, but the main criteria for the informant had to be that they needed to be someone that knows the older adult the best. Also had to speak one of the 4 dominant languages, and this particular toolkit was asking questions about their own health and well-being, as well as that of the older adult, and also some questions about the household itself. We selected 2 provinces for pragmatic reasons. The Western Cape was our urban setting, and the Limpopo side would be our rural representation. For the Western Cape, we focused on the Cape Town area and included 5 wards. These wards were stratified in terms of income. So we ended up including 1 high, 2 middle, and 2 low income areas, wards in our survey. We selected households using a randomization, but specifically the PPS method. We identified a starting point, a route to follow, and then an interval was applied that was based on the population size of that particular ward. We did things a little bit differently in the Digale area. Digale was part of the Dimamo health surveillance site. So we worked very closely with our partners at the University of Limpopo, who provided us with a sampling frame, and we could pre-select households within the 14 villages using simple randomization. Yes, so we targeted initially 400 households per site. But in the 2 months that we had to collect the data, we managed to complete surveys in 490 households. So let's look at the findings. A quick description on our sample. The average age in our sample was 74.6 years old. We had more females than males in our sample. And in terms of education levels, we found that there were higher levels of education located in the more urban settings than in the rural, which is expected. Just some context on how the 1066 short algorithm was applied. We had to exclude 82 households due to missing data. And this was largely because of participant refusal to either answer certain sections of the toolkit, or it was due to field research or technical error. So we also found that the ability to run the algorithm is not associated with age, sex, or literacy. Dementia prevalence was estimated at 13.7%. But when we weighted those figures by national age, sex, and literacy estimates, that figure decreased to 11.8%. So this is still a lot higher than the initial 2 to 4% range that was previously estimated for the sub-Saharan region. We also found that, of course, this is also in line with a smaller study that was done a few years ago, also in the Cape Town area, had estimated dementia prevalence for South Africa to be around 11%. So we found no significant differences between males and females. We did, however, find a greater likelihood of dementia in the older cohort than the younger one, which is the age expected trend we expect to see. We had a look at the diagnostic services and access to diagnoses that the older adults had were able to obtain, and we compared hypertension, diabetes, heart trouble, and stroke with dementia. And as you can see on the screen, in terms of the figures, only one individual was able to access a formal diagnosis for dementia. So in comparison to the other illnesses and other conditions, it seems that there is a lack of access to diagnostic services for people living with dementia. In terms of care needs, we found that most adults in the sample did not need care, which is expected. However, about 86% of the older adults identified with dementia needed care, and this is according to the report from the informants themselves. About half of that figure indicated that the older adult needed care much of the time. So as expected, dementia was significantly associated with care needs. But this also shows us that the need for care and support is located at the community level. And this is important considering that most of the people that we identified with dementia in the sample did not have access to a formal diagnosis. So who are the carers? We found that most of the carers were adult children, either the son or the daughter, or it was the spouse, another relative, or the daughter or son-in-law. When we looked at the employment status, if we exclude the ones that indicated that they were retired, we found that most of the carers were economically active at the time of the study. It's not on the screen, but we also found that most of the carers were female, just about over 80% were female. If you look at the graph on the screen, you can see that care is something that happens within the network. And for this particular sample, support was provided by either one or two carers at least. Some key points that comes from the study. Our analysis shows that the dementia prevalence in South Africa is high and increases with age. We also show that diagnostic services for dementia compares poorly to that of other diseases, and that the majority of people identified with dementia reported that they needed care, and that happens within the family context. Most carers in this case were female and economically inactive. Some quick takeaway messages. In terms of prevalence, we need to increase awareness and understanding of dementia in South Africa. We need to know that it is a public health concern that needs surveillance and monitoring, and that is not currently happening now. There's a need to target modifiable risk factors, promote healthy aging, and have a coordinated intersectoral response. In terms of community-based responses, we are aware that we need to strengthen our approaches to health and social care and how we provide support, and that we need to focus on the family. This includes having access to healthcare services like diagnosis, treatment, and care, but also that home-based care and support to alleviate the impact of the social or the economic impact of providing support to family members, that to provide support to that particular network. Also, in line with philosophies like promoting healthy aging and aging in place, we need to strengthen our approaches to make sure that we take care of our older adults within their contexts where they stay active and they participate actively within societies, within their networks, within their homes, within their communities for as long as possible. Just some images from our STRiDE field researchers that helped us last year to collect the data. Yeah, and thank you from us. This is a South African.
Oh, I love that last slide. Okay, thank you so much, Roxanne. Fantastic. It's so important to start getting that real primary data, which discussion we had yesterday when we had a discussion around global burden of disease. So now we're back in real life, and we've got Janelle Robinson from the University of West Indies, who's going to talk about mapping out long-term care in Jamaica.
Hello, everyone. Thank you, Wendy, and special thanks to the STRiDE project. Before I begin, I just want to acknowledge my team members who were unable to make it today: Rochelle Moore, Tiffany Palmer, Marissa Stubbs, and our project lead, who is here, Dr. Ishtar Gavayo. So thank you and special acknowledgements. So this case study was actually published last year, and it was the first of its kind in Jamaica to really provide a comprehensive overview of our long-term care systems and services, as well as assessing the capacity of this system to meet the long-term care needs within Jamaica, while highlighting the system gaps and the service gaps and how exactly can these be addressed. So to provide some context, within Jamaica, the highest growth rate is actually among the age group 80 years and older. And it's estimated that by 2050, the age group 60 years and older will account for almost 20% of our population. And currently, they only account for 12%. Additionally, in the context of Jamaica, almost 71% of older persons are living with at least one NCD. And similar to the other STRiDE countries, the prevalence of dementia is rapidly increasing given the aging population. But what's increasingly worrying about this is that less than 20% of our population currently receive insurance. And even fewer persons from the older population has access to health insurance. And unfortunately, there is little evidence and little documentation about our long-term care system, which is why it was so important for us to really conduct this study. So to achieve our objectives, we conducted empirical and great literature review, and this was supplemented by interviews, focus groups discussions, consultations, and other knowledge exchange activity, and this occurred throughout the duration of the STRiDE project. So now we're at 4.5 years. So it was an immense amount of data that we used to really put this together. And in terms of the stakeholders, these included policymakers, government officials, caregivers, particularly caregivers of persons living with dementia, as well as health and social care professionals. So using this data, from the data collection, we were able to graphically map Jamaica's care system, particularly for older persons. So right here we have the 4 quadrants. To your top right hand, you will see mapped here the long-term care services relating to residential facilities but independent living. To the top right, you will see residential services but related to those that would definitely need intense care. The bottom half of the quadrant really maps out the community-based services and providers that we have in Jamaica. And I'm going to spend a little more time on the community-based services as well as and the providers, and we're going to touch a bit on the residential aspect as well. Now, similar to other countries, as was shared in previous presentations yesterday, overall, the long-term care needs within Jamaica are primarily carried out by our informal care sector. And when we talk about informal care in Jamaica now, because we don't have any structured data collection or systematic data collection as it relates to long-term care, there's not a clear sense in terms of the size, the composition, the characteristics of both the providers and recipients of long-term care in Jamaica. But what we do know from our STRiDE work and other local studies is that the informal care workers are mainly women. They're mainly from our rural communities, and they're mainly older persons. And unfortunately, they're also from lower SCS status. And we'll speak a little bit about that because that has serious implications on when we talk about the informal care market. Additionally, our domestic workers. Now, the domestic workers in Jamaica is a staple within many of our households, and they have become the de facto caregivers within these households. So in addition to providing caregiving duties, they're also doing their domestic duties. They're cooking, they're cleaning, and none of these individuals within Jamaica have received any formal care in elderly care or dementia-specific care. Again, this has obvious implications. Then we have our NGOs. Our NGOs also play a crucial role in terms of providing long-term care support within Jamaica. But to be very honest with you, it's not a sustainable model, particularly because much of the NGO are usually funded through charitable donations or self-funded. And in terms of what the support looks like, it's financial support or support with basic necessities, so like food and toiletries. Then we have our churches and our faith-based organization. I'm not quite sure who in this room is actually familiar with Jamaica, but fun fact, Jamaica has the most churches per square miles and bars in the world. So it is not surprising that places of worship are also intertwined in terms of providing long-term care services to our population. And that's not just spiritual support, it's also food, it's also monetary support. And we do have, to a lesser extent, where the church members have been able to provide some form of respite care. So a church member may go to a fellow church member, okay, listen, I am going to look after mommy or look after daddy or look after your loved one so you're able to get some sleep, so you're able to go to the supermarket. So that's also a very common practice within our society. Now, as it relates to residential care, this is provided in both the private and public sector, similar to Fabiana in her presentation as she outlined that context as well. However, within our private residential facilities, unfortunately, we have less than 1% in terms of registration rates. That has implications for the quality of service that's provided, what then is being monitored, right? And we'll speak a little bit more about that, and I'm hoping that we'll have some questions from the audience during that time. Additionally, as it relates to our private residential facilities, it's mainly accessible to persons from the high SES group. And even then, we do not have insurance coverage for private residential facilities. And then we're now speaking to our state-sponsored residential homes. It sounds very fancy, but within Jamaica, we only have 19. And of those, only 2 are specific for older persons. And to provide further context, if we were supposed to combine the bed capacity of all 19, they would only be able to address the long-term care needs of less than 0.01% of persons 60 years and older. So there's much needs to be done as it relates to that. Additionally, our study also found that there have been very little attempts in terms of trying to govern and trying to finance our long-term care system or lack thereof. However, I will just highlight. So currently, our long-term care services are met across 3 main ministries. However, these ministries operate independently. which most likely is really guided by the budgetary constraints and the budgetary allocations and how that has to be spent. But they do not communicate, though providing overlapping services. And their services are not well known either. As it relates to financing, much of our long-term care system and our services is really financed out of pocket, but I will highlight these. We have our national insurance scheme. Unfortunately, our national insurance scheme, from our research, is pretty much available to the richest quintile in Jamaica. Actually, 80% of those from the poor quintile are not eligible for this insurance scheme. And this insurance scheme as well, it doesn't cover residential care costs, whether it be in the public or private sector. Then we have our PATH program. Interestingly about our PATH program is that almost 75% of the recipients are actually from female-headed households. As we all recall before, in terms of the informal carers that provide long-term care services, they're also females. Additionally, 16% of the recipients are also individuals who may be older persons or living with a disability. Recently, during the pandemic, our government actually initiated a social pension program, particularly for people 75 and older. And it sounds really nice, but unfortunately, the coverage for this program is less than 12% of the monthly minimum wage. So forgetting long-term care needs, it's not even able to afford the basic necessities that they would need. Then we have remittances. Now, I'm not quite sure if everyone knows what remittances are, but Wendy, we can always go through that during the question and answer. But remittances is also a staple within our society. And in terms of remittances, in the extent of its importance in Jamaica, it has significantly contributed to our GDP over the years. This is also a cultural phenomenon with Jamaica as well. And through our research, we found that almost 100% of caregivers particularly have been recipients of remittances, either as their only source of income or supplement to their income. However, not much is known in terms of the direct connection in terms of how it contributes to the finance of the long-term care system, which is clearly an issue which I'll get into now as it relates to the gaps. There are clear gaps in Jamaica's long-term care system, and this is not an exhaustive list, but just to highlight and to reiterate, because this is important, is the heavy reliance on women, particularly women from rural communities, because when these women relocate, you create a deficit in these communities. Additionally, there is little strategic coordination on the national and local levels across the ministries that were mentioned before. Additionally, with no LTC-specific insurance coverage, much of the payments and the services, all of that is financed out of pocket. And again, it disproportionately neglects those from the lower SES. And what it does inadvertently is really, it widens that gap as well. It widens that inequality. Additionally, there is a lack of systematic LTC data gathering. So what are some of our key takeaways? Jamaica has to take stock now. It's not an if, a but, or maybe. We have to take stock now. There has to be very clear actions at the national level. It has to be coordinated. Additionally, family caregivers within Jamaica, they need reprieve. They need to receive some form of compensation, and they need to have access in both rural and urban communities to additional care support. Also, there has to be legislation put in place to ensure the appropriate monitoring and financing of our long-term care system, which is non-existent right now. And what we appreciate with this case study, and I also have to highlight Adelina, who actually pushed us to do this as a part of Work Package 7, is that it also provides a foundation for other low to middle income countries to really critically assess their own long-term care system, identifying the gaps, and also formulating culturally appropriate and relevant recommendations to address the system gap. I thank you all very, very much and do enjoy the last presentation.
Well done. That's super, super. That was fantastic. Thank you so much, Janelle. Now, last but not least, and I'm pushing it now because we've got our 10 minutes left, and I want to apologize to you, Dr. Fifi, because she's come all the way from Indonesia and she's had to crane her neck during this entire hour and a half. So do you want me to rub it while you're talking? Anyway, so this is Dr. Fifi, who's are you from Atmajaya? No, you're not, because I don't have it written down here. She's presenting on behalf of Dr. Yuda, who is from Atmajaya, and she's going to be talking about a very similar study that we talked about in South Africa about prevalence in Jakarta. Thank you.
Okay, thank you, Wendy. Thank you, the committee, and thank you for the STRiDE program. So, it's an honor to be here. I'm speaking on behalf of Professor Yuda Turana, Dr. Tarasani, Ms. Imelda Teresia, and all the colleagues that have worked so hard, and also Dr. Nicholas Farina, from whom I learned a lot during this project, so thank you very much. So today I'll be sharing just a minor, not a minor, just a part from our finding about prevalence in Indonesia, finding from STRiDE study. So as a background, Indonesia is the fourth most populous country in the world, and it is currently facing an increase in aging populations, and along with this, there is an increase also in number of people living with dementia. However, until now, we don't have a national dementia data prevalence. So far, the data about prevalence of dementia in Indonesia comes from either an estimation from the calculation or statistical calculation from global burden of disease, or from several regional data from several regions and provinces in Indonesia, which so far showed the high prevalence of dementia compared to international or global data, which ranges between 5 to 7%. And there are several contributing factors for this high prevalence of dementia in Indonesia, but the most important one is the low level of education in populations, but also there is an increase in many diseases that also act as dementia risk factors, such as diabetes, hypertension, stroke, based on the National Health Survey in 2018. And also to provide context, we know that so far, these are the prevalence data from Indonesia. Most of these studies conducted in island of Java and one from Bali. And the results show the prevalence range from 20% to as high as 30% in Bali. And the recent data from STRiDE project in Jakarta and North Sumatra, where I come from, Wendy. So I come from that little, my hometown is there in island of Sumatra. I come from University of Sumatra Utara. So it shows a similar number, 23%. So the difference in these numbers mainly due to difference in methodology, sampling strategies, sampling size, but also the instruments used in this research. And also the unique challenge in conducting dementia research in Indonesia is the lack of culturally appropriate cognitive tools, because most of the instruments, most of the cognitive tools that we have derive from translations from other languages, primarily English, and it can pose challenges when applied in a very culturally diverse nation. As Indonesia, we know we have hundreds of ethnic groups. We have 270 million people living in more than 17,000 islands in Indonesia. So, but for this STRiDE, I know we have a STRiDE toolkit that has been translated and culturally validated. So all the items were able to measure what they were originally intended to measure. So I'm aware of the time. So this was a cross-sectional study conducted in 2 provinces in Indonesia. I think it is it is the first studies conducted outside the Java Island. So in each province, we randomly selected district and then sub-district areas to identify eligible participants. And we included older adults aged over 65 years old and have informants to provide information and able to speak Bahasa Indonesia. So this is the instruments that we use other than demographic characteristic, very similar to what in South Africa, also because it's in the same work package. We use CSID that has component of cognitive assessment and also informant component about functional impairment, and the SERA 10-word list learning, and EuroD, a self-report measure for depressions that compose the 1066 short diagnostic schedule and algorithm. So I'm sorry for the diagram. So the initial target for Indonesia was 2,200, and we managed to recruit the target number of 2,200 participants despite the pandemic. But the final number in which the diagnostic algorithm can be applied is 2,110, which is quite great, I think. So this is the comparison with other provinces so far. So just to highlight the finding that the prevalence of dementia is somehow similar despite the difference in methodology and in the instruments used, and also the sampling size. The most recent one is from the Jatinangor. It's one area in West Java, which also found 20-something%, and all of these studies found higher prevalence in female compared to male, and most of and in all of these studies we found low educations in the participants, which contribute to the higher prevalence of dementia in Indonesia. And so the prevalence in Jakarta and North Sumatra is also similar, 22 and 24. So this is just to highlight that we, although we don't have nationwide data on dementia prevalence, but we have data about the increased prevalence also for the diseases that contribute as dementia risk factors that might also contribute to the high prevalence, like hypertension, diabetes, stroke, depressions. Okay, thank you.
Thank you so much. It's a lot of data. Keep it short. Well done. Okay, that's amazing. We've gone slightly over time, and I don't know, but there's so much to tell you about STRiDE, as you can see. And these amazing women have done such a great job. And you've been amazing for sitting as long as you have. Does anyone, listen, I'm going to tell you, if you really want to hear more, you've got to come to this event, because there are going to be even more people speaking, and we'll get you up moving around. Does anybody have a question that they want to ask? A burning question. Mariella. I can.
Thank you to the speakers. A great project, really, especially for low and middle income countries. Two questions. It's a 4-year project, and numbers are quite different, and especially that from Indonesia, 20% of prevalence is really very high. So my question is the impact in public health and social and the civil society of your results. And the second is, why have you used the short version of the 1066?
Do you want me to? Would you like to go for that?
Okay, thank you for the questions. To be honest, for the methodology, I might ask Dr. Nicholas Farina to help me answering this. But yes, the finding from Bali was surprising because it showed as high as 30% dementia prevalence, and there was discussion about that, what makes it different. But I think the most important factors, the most important difference is the diagnostic criteria they use, and also the instruments that they use. But also there's a higher level of stress and stress and psychological burden from that area. And for the 1066? Okay, please. Because it's part of the work package 5, and there's the...
Thank you. Well, didn't expect to be on the stage.
We have a seat for you. So.
Yes, so really we wanted to build upon we acknowledge the great work of the 1066 project and all the the fabulous work they've done to kind of establish the toolkit. And I think something that we were vigilant about was that when we were collecting this data, we wanted to not only estimate the prevalence, which is obviously what we heard about today, but we wanted to also capture the impact of dementia in Indonesia and in South Africa. And so something that we tried to prioritize is to include this holistic set of measures. And once we looked at the full 1066 schedule, we realized that that starts taking quite a lot of time. And so it was one of our, well, it's probably not a compromise, but we decided that actually we wanted to prioritize some of these other measures to ensure that we're capturing this kind of comprehensive set of outcomes for this novel data set.
Thank you, Nick, for coming from the audience, too. Do we have time for one more question? I'm looking at the people in the back. One more? Is that okay? One more? Anybody have anything for us? No? Okay. Listen, I'm going to draw this to a close, but I want to thank all of the speakers, both live and virtual, and thank you for sitting this long to listen to our story. And please come and join us next week on Wednesday, the 15th. The leaflets are on your seats. There is more of a story to tell. There is going to be more of STRiDE. And thank you for joining us today.
How beauteous is mankind, O brave new world that has such people in it.
Stop sitting around in your comfy chair. Gaze out of your window, look what's there. It's a